Hello, ladies and gentlemen. My name is Adam Bollmeyer, and I am the Fertility Clinic Liaison for the Embryo Adoption Awareness Center. Today, we are very pleased to bring you a brand new webinar, Medicine and the Donor Child. Joining us today are a pair of expert presenters. First is Dr. Noel Graham, who is a pediatrician. Dr. Graham has been with Preferred Pediatrics since 2006. He attended the University of Kansas School of Medicine, graduating in 1999. He completed his residency at Children's Mercy Hospital in 2002 and has been in private practice since. He is a board certified in pediatrics by the American Academy of Pediatrics and is recognized as a fellow by the AAP, the highest distinction for this organization. Dr. Graham has a special interest in the treatment of asthma and allergic disorders. In addition, he has a degree in genetics and sees many patients with genetic syndromes. He is the current medical staff president at St. Mary's Medical Center in Blue Springs, Missouri, and he is married with 2 children, a son and an embryo adopted daughter. Co-presenting today is Ms. Wendy Kramer, the co-founder and executive director of the Donor Sibling Registry. The DSR is a charitable organization founded in 2000 by Ms. Kramer and her donor-conceived son, Ryan. Its purpose is to assist individuals conceived as a result of sperm, egg, or embryo donation who are seeking to make mutually desired contact with others whom they share genetic ties. Wendy has co-authored several published papers on donor conception, has reviewed abstracts for the American Society of Reproductive Medicine, and has also been a peer reviewer for the Journal of Human Reproduction and RBM Online. Wendy and her son Ryan have appeared on 60 Minutes, The Oprah Winfrey Show, Good Morning America, and many other news shows and publications. Before we start, though, we need to take care of a bit of housekeeping. During today's presentation, all participants will be in a listen-only mode. There will be a question and answer session at the end of the presentation using the questions you submit through the Q&A feature. You may submit your questions at any time during the presentation, and we will answer as many as possible at the end of the presentation. To ask a question, simply click on the Q&A panel in the lower right-hand portion of the screen. Type your question into the dialog box and click the Send button. If you happen to be in the full screen view, you can click on the question mark icon on the toolbar in the lower right-hand corner of the screen. This will open the Q&A panel on your screen only. When you submit a question, it will be visible to all of the panelists, but not visible to other attendees. We expect today's presentation to last approximately 45 minutes, and then we'll take the last 15 minutes for the Q&A. As a reminder, we will be distributing a copy of today's presentation along with a comprehensive list of answers to all questions submitted today. If you are experiencing any technical difficulties during the presentation, please contact WebEx Technical Support, and this number is at the bottom of the screen, at 866-229-3239. As a reminder, this presentation is being recorded. And with that, I believe we are ready to start. So I will throw it over to Dr. Graham. Dr. Graham, thank you so much for being with us today.
Yeah, thank you for that introduction, Adam. It's a pleasure to be talking to you guys today. As Adam alluded to, I've been a pediatrician in private practice for the last 11 years, and I have intimate knowledge of infertility and the embryo adoption process, as my wife and I have experienced both of those. We were married in 1999, right before I started residency, and kind of made the decision that we did not want to have kids in residency since I was going to be working 100-hour weeks and I wouldn't really be there to raise them. And so we put off having kids until I was done, and so in 2002 we started attempting to have a child, and we had about 2 years of futility before we sought help from a reproductive endocrinologist. And after all the testing, nothing was found to be abnormal. We just were not having kids. We went through all of the typical reproductive interventions up to and including in vitro fertilization. Our first attempt at IVF was rather dismal. We produced about 2 or 3 follicles, and so we actually aborted that first attempt, and they kind of changed up the medications, and we tried again. And the second attempt was a little bit better. We had 4 follicles, and we decided that was probably the best we were going to do, so we went ahead with that. And we got 2 embryos out of it, one of which did not look very good, so our reproductive endocrinologist made a decision to do a 2-day transfer. And fortunately, we had one that took, and 9 months later, we had our son, Elliot, who is now 7 years old. We started again about 1.5 years after that, and made another attempt at IVF, and it was, once again, it was 2 eggs or 2 follicles, and we made a decision not to go through with that. And then in talking to our reproductive endocrinologist, we decided to pursue other options. And at that point, we had certainly the option of doing donor eggs with my sperm. Also had the option of going through traditional adoption, either here or abroad. This was kind of when they were winding down. Most countries were not allowing adoption of their children out of the country, and it's pretty much closed now, with the exception of kids with special needs in China and Russia. And then they presented us with the third option, which was embryo adoption. And the more we looked into this, the more we liked the idea. Some of the advantages we saw with embryo adoption were, one, we weren't putting another person at risk. Certainly the process of getting donor eggs is safe for the most part, but there is a risk involved in that. And we had a genetic child, so it wasn't really as important to me that that it be genetically related to me, the next child. So we decided that probably wasn't a great option. And then traditional adoption was also something we considered and absolutely would have gone through with, but as many of you know, the waiting list for that is long, and oftentimes the kids are drug exposed or come from backgrounds that are that you would not as desirable, and so we decided embryo adoption was probably the best choice, and decided to go through with that. Now, the process of embryo adoption is actually very similar to a traditional adoption. We met with a social worker. We did a home study, and we went through Nightlife Christian Adoption and the Snowflakes program. And we started that process in 2009, and we were matched with a family in Florida. And in 2010, our daughter Meredith was born. Next slide. This is Meredith. She just turned 3 years old in June, and she has 2 full genetic siblings who live in Florida, and she actually met them about 1 year ago when we went to did a Disney vacation. And my wife is actually good friends with their mother. Her siblings in Florida are the product of donated eggs and the father's sperm. So we actually know half the genetic information and can give good family history from the father. But the other half, the donor mother, is anonymous. We do not have really any information other than the snapshot that was provided to us when she first went through the donation process. And so there is some uncertainty, not only for us, but for Meredith's genetic siblings. Next slide. So now I'm going to talk about some of the things that, as a physician, we're going to look for, not only in terms of family history, what the types of genetic disorders and the influence the inheritance is going to have on those. Next slide. When we talk about typical, Mendelian inheritance, we have, autosomal dominant, autosomal recessive genes. With the dominant genes, you're going to need one copy to have to cause a disorder, and typically you're going to see, multiple cases in the family. Multiple people are going to be affected because, if it takes one gene, then 50% of the people are going to have that gene on average. But there are a lot of new mutations as well. There's some of the autosomal dominant genetic disorders. The vast majority are due to new mutations, and an example of that would be achondroplastic dwarfism. 90% of those are new mutations, and there is no family history of that. In terms of some of the disorders that we see that are autosomal dominant in nature, Marfan syndrome, which is a disorder of the connective tissue, involves the fibrillin gene, and this can be anywhere from very mild illness to severe illness. These are going to be characteristically tall individuals. A lot of times they'll have scoliosis, nearsightedness, may have things like retinal detachment, and then with Marfan syndrome, the big thing we worry about is aortic aneurysms. With familial hypercholesterolemia, this is a mutation in the gene encoding the LDL receptor protein, which actually clears the LDL from the bloodstream. So heterozygotes, if you carry one copy of this gene, you're going to be prone to having cardiovascular disease in your early 30s and 40s. Whereas typically, if you do not carry a copy, most people are not going to experience cardiovascular disease until 50s and 60s and above. If you're a homozygous for this gene, meaning you have carried two copies of it, these are young when they experience cardiovascular disease, and we're talking about 10 and under. So these kids are treated very aggressively with cholesterol-lowering medications and diet as well. And then the neurofibromatosis type 1. That is a tumor disorder causing tumors along the nervous system, and you have various degrees of expressivity in this disorder. It can be very mild and oftentimes not diagnosed until much later in life, or it can be very severe and it can be diagnosed when the kid's a couple of years old. Next slide. With the autosomal recessive genes, you have to have two copies of a gene in order to cause a disorder. So because of that, chances are there may not be a family history. If you have some of these disorders, there may be somebody in the family that has it, but most of the time there isn't. Some of the examples of kids that we see are cystic fibrosis, which is a disorder of the CFTR gene, and that controls chloride movement in the skin and in the lungs. And so these kids are going to have very thick mucus because they cannot get chloride across their lung cells. And so if they can't get chloride, they can't get sodium, and they can't get water. And so the thick mucus leads to infection and a lot of lung issues, and this also can be very mild or it can be very, very severe. And these kids can oftentimes will present with lung issues, but also failure to thrive because it can involve the pancreas as well and their ability to absorb fat and nutrients. Sickle cell disease is a disease where the blood tends to form a sickle shape, and that is also the trait condition is fairly common, as is a trait condition with cystic fibrosis, because in both of these conditions, the heterozygotes, if you just carry one copy of the gene, actually may have an advantage over people that do not have a gene. And in the case of cystic fibrosis, it's thought that this protected against cholera. So if you had one copy of the gene, you were much less likely to get severe cholera, less likely to get dehydration, and 100 years ago, 200 years ago, that would have eventually, to a lot of people, led to death. And so if you had one copy of the gene, you were more likely to live and more likely to pass your genes along. Similarly, with the sickle cell disease, we see a relative resistance to malaria, and so they're more likely to less likely to get malaria, more likely to survive, and that still is, you know, of course, a concern in much of Africa. PKU, is phenylketonuria, and that is a disorder of phenylalanine metabolism. And for those kids, if they're exposed to phenylalanine, it produces toxic metabolites that can actually cause brain damage. Anybody who, whenever you drink a Diet Coke or something, and it says on there that it contains phenylalanine from the aspartame, that they're basically telling the people with PKU that they should not consume it. And then a lot of the glycogen storage diseases that have deal with the body's ability to access glycogen stores, and there are several of those. Next slide. X-linked disorders are mostly going to affect the males. Males carry one copy of the X chromosome, females carry two, and so the females, if one copy is often enough to avoid symptoms of a disease. Females are often carriers, and so they are going to pass it on to half of the boys that they have, and half the girls are going to be carriers if they carry one of the X-linked disorders. The two most well known are hemophilia, which is a blood clotting disorder, and then Duchenne muscular dystrophy is a disorder in the dystrophin gene, which encodes for structural components of muscle tissue, and this can lead to muscle degeneration and ultimately death. Next slide. Mitochondria are basically the powerhouse of the cell, and all of our mitochondria, or essentially all of it, come from the mother. And if you think about it, it makes sense. The egg is, hundreds of times bigger than a sperm, and so the sperm has some mitochondria in it, but when you look at the egg, you're talking 100,000 times more mitochondria than the sperm. So all mitochondrial disorders are going to be passed on from the mother. They're rare in general. There's a lot of mitochondrial dysfunction may play a role in a number of disorders, but the specific mitochondrial disorders are fairly rare. Some of the examples of them are the Leber's hereditary optic neuropathy and the Lee syndrome. Next slide. Epigenetic disorders. This is a group of disorders that encompasses the way the genes are imprinted or expressed. You can have identical copies of DNA, and with the addition of methyl groups and other imprinting, they can be transcribed in completely different ways. And so we actually have maternally imprinted genes and paternally imprinted genes, and you need both copies. You need a copy of maternal and paternal imprinting. And if you don't, if you have both maternally or both paternally imprinted genes, then you are at risk of some of these disorders. The most common and well-known disorders are Prader-Willi and Angelman syndrome. Prader-Willi is this leads to kids that basically have an insatiable appetite. These are kids that you have to put locks on the refrigerator because they will literally break into things to find food. They are never satiated. Leads to morbid obesity very early. It's a very difficult disease to control. And then Angelman syndrome is often called happy puppet syndrome. They are basically very happy kids, but their intellectual ability is limited. Next slide. The disorders I've already talked about are actually, in terms of medicine, are fairly rare compared to disorders that are going to be the multifactorial or the polygenic. These are involving multiple genes. and often have both lifestyle choices and environmental factors are going to play a role in these. In the case of things like heart disease, asthma, cancers, allergies, hypertension, the ones listed here, there aren't specific genes that you're going to say, well, we can test for the asthma gene, or some cancers have a specific gene, but most cancers don't. Most cancers are associated with multiple genes, and same with heart disease and allergies. There may be a tendency toward them in a family, but there isn't a gene, at least as of yet. And with, as we get better at testing for things, and we may be able to find, multiple genes that are associated with something, but for the most part, this is going to be an interaction with multiple genes and environmental factors as well. Next slide. So what does all this mean to us as physicians? Why do we really care about the family history? Next slide. In addition to asking a personal medical history, one of the things we're going to do is we're going to ask a detailed family history, because as I've alluded to, with some of the single gene disorders and the polygenic disorders, what you have in your genes, tends to control a lot of the disorders that you're going to experience throughout your lifetime. And more than anything, people want to know a diagnosis. What is more frustrating than anything to people is when they walk away from the doctor's office and they don't know what the diagnosis is. It may be this, it may be that. People dislike that more than they dislike the weights or the expense. And studies have shown, especially women, that is the number one complaint, is that I don't have a diagnosis. I have things that may be wrong, but I don't know for sure what it is. Knowing a proper family history can help us with this. Next slide. Early diagnosis is going to lead to early treatment, and this makes sense. If you have familial hypercholesterolemia, we're going to put these people on statins very early. We're going to limit their dietary intake of cholesterol, and we're going to be doing a lot screening a lot earlier as well. With hemophilia, this is typically treated with factor replacement to prevent bleeding episodes. And if we know early that this runs in the family, then we can do testing early, we can treat early, we can avoid doing things like circumcision with hemophilia, because that can lead to excessive bleeding, and sometimes can actually lead to the diagnosis if there isn't a known family history. And then with things like PKU and galactosemia, these kids need to be put on a special diet from day one. With galactosemia, they need to be on a soy formula. They cannot breastfeed. They cannot be on, most of the typical formulas, because they can't have lactose. And if they do have lactose, this is going to lead to buildup of some of the metabolites and brain damage and liver dysfunction. And fortunately, PKU and galactosemia are two disorders that are universally tested on newborn screens. But if we have a family history of them, we can actually, before we get the testing done, because that takes usually a week, 10 days to come back, we can put these kids on these special formulas before we even have the testing. And then if we need to, we can switch them later. But ideally, you do it right away, so you're not going to have the potential for causing any brain damage. Next slide. And then, like I alluded to with the hypercholesterolemia, you're also going to have the possibility for early screening to avoid complications. With Marfan syndrome, the main complication is going to be with aortic root aneurysms, and with this, we want kids to avoid, a lot of the strenuous exercise. These are kids that we tell not to do, like the weightlifting and anything that's going to increase pressures. And we'll do echocardiograms to make sure that they're not developing any aneurysms with their aorta and aortic valve. And then with Ehlers-Danlos syndrome, that's also a syndrome that can affect the heart and blood vessels. This is kind of kids that you see or adults that you see that are very limber, have hyper flexibility. Beckwith-Wiedemann syndrome is something that we also see in kids, and these kids are at about a 600 times higher risk of Wilms tumor, which is a treatable form of kidney cancer, one of the more common kidney cancers that we see in kids. And with this, we would have kids being screened early with alpha-fetoproteins and abdominal ultrasounds, initially even as often as every 3 months. And then the risk can go down. But obviously with that, early tumor detection is going to lead to better survivability. Next slide. But probably the greatest potential is to reduce disease risk is when we talk about the polygenic disorders, is to modify the lifestyle, environmental risks. With things like asthma, we know that breastfeeding is going to reduce your risk of asthma. Avoiding tobacco products. This is going to mostly be secondhand smoke. Kids that are around secondhand smoke are much more likely to develop asthma than kids that aren't. There's some interesting studies going on with the introduction of foods and the timing of the introduction of foods. With asthma in particular, we've found that introduction of certain fish in a certain time period has led to a reduction in asthma, and that still needs to be sorted out. But it's easy enough to tell people to introduce fish between 6 and 12 months to reduce their asthma risk, and it's not a big deal. And then avoidance of daycare. If we know that the more you're exposed to viruses, upper respiratory infections, the more likely you are to have asthma as well. And so kids that aren't in daycare are not going to be exposed as much. And then the probiotics. With the allergic diseases in general, there's been a lot of studies done on probiotics, and the results are kind of conflicting. But it's certainly a relatively benign intervention. It's not going to cause any negative effects. So if there's a strong family history of the allergic disorders, having mom take probiotics while she's pregnant and then continuing them for the baby is certainly not a difficult thing to do and relatively inexpensive. With the hypertension and heart disease, of course, avoidance of tobacco products. Diet and exercise, and then early monitoring, of course. Next slide. With the cancers, strong family history, it can be, certainly avoidance of tobacco products. And pretty much avoidance of tobacco products helps with just about everything. And then a lot of the environmental triggers, you can have things like, toxins you're potentially exposed to, but even, whether it's red meat and increased risk of colon cancer, or there's a lot of things that you can change and avoid that may decrease the risk. We know people that eat more vegetables are less likely to have certain types of cancer. So a lot of it is in diet and then avoiding some of the environmental triggers. Radon is the second most common cause of lung cancer. So if you're in the Midwest, we have a lot of people will test for radon in their homes because it's it's a natural product, and you can't really avoid it unless you know it's there. Then you can do special venting. And then with obesity, we know that breastfeeding is going to prevent obesity to some degree. We found that introduction of solid foods before 4 months of age increases the risk of obesity. And then just the monitoring of the diet initially, especially avoiding sugared beverages, whether it's juices and pops and lemonades and sweet teas, all of those. We know that increasing those is going to increase the risk of obesity. Next slide. Some of the examples that I have seen, personally in my practice, just even over the last, in one case over the last couple of months, I had a 5-year-old it's probably a couple weeks ago, that had a mother was 25 years old. She was adopted, so she didn't have a whole lot of history, and she came in for her first visit and going over the family history. Mother had actually been diagnosed with colon cancer at age 22 after she had her child, and she sought out her biological parents and found that there were relatives in the family, and everyone had developed colon cancer at an early age. And her ultimate diagnosis was she had familial adenomatous polyposis. And this is a autosomal dominant gene, and her son was tested, and he does have the gene. So this is not only going to lead to early screening for him, because we're going to do colonoscopies at a very early age. We don't typically do colonoscopies in 10-year-olds, but he'll be getting one. and then early detection of these potential tumors. And with this disorder, if you live long enough, you're going to get colon cancer. There's 100% risk by the age 40 or so. And then, within this, it was obviously occurring at a very young age. But if mother had known this, she could have, and she's doing well now, but she could have had, screening earlier for herself as well. And then we had a 6-month-old who had gotten his vaccines and presented the next day with just extensive bruising on his legs. And, of course, the thing you worry about most in those situations is things like abuse. And in getting the family history from Mom, I talked to her about, is there anybody that has a bleeding disorder in the family? And she said, oh, yeah, my cousins do, but and they've got hemophilia, but I don't have it. I was tested and I'm negative. Well, she was tested 20 years ago, and obviously the test was wrong. But she had not really disclosed that in her family history. We've been seeing the boy for 6 months, and she hadn't disclosed that because she felt that she was negative and therefore it wasn't something to worry about. Well, he was found to have factor VIII deficiency and was started on factor replacements and is doing well. I had actually circumcised this kid when he was born, and he did not have much in the way of a bleeding problem, so we were fortunate in that regard. But he's doing well now on factor replacement. But it's one of those things that even if you think, it's good to let the physician know about your family history, even if you think you don't have something, because testing always gets better. And so in this case, it would have been good knowledge because we would have tested the kid early to make sure that he didn't have a factor VIII deficiency. All right, and next slide. With that, I will turn it over to Wendy.
Thanks so much, Dr. Graham. That was really informative. Unfortunately, I do recognize many of the medical issues that you mentioned as being reported by families on the DSR, so that's a little frustrating. We can go to my first slide. So for those of you who don't know me, I'm Wendy. I run the Donor Sibling Registry, which was started in 2000 by my donor-conceived son and I, out of his own curiosity. So we have now more than 40,000 members on the DSR, and we have quite a bit of information about families and what we've all dealt with sort of after the infertility and after the pregnancy. So what we do know is that more often than not, donor-conceived children and their families have very limited information about their donor. Next slide. Usually it's a snapshot of one day in the life of a healthy young college student or a young woman in her 20s. We do know that sometimes they don't tell the whole truth because of fears of maybe not being accepted by the program. And sometimes they just don't know their family medical history. They don't know what grandpa died of, or sometimes there were things that were kept from them because they were children. So it's we don't get a full, complete history a lot of the time. And we don't know what happens the next day or the next week with the donor or his immediate family. And families, when they're choosing donors, they might look at a donor and his medical history might look clean and terrific, with just minor things on there. But what they don't know is that this donor might already have 30 or 50 or 100 kids out there, with a large group of them reporting things maybe not life-threatening, like autism, ADD, Asperger's, things like that. Next slide. So when you have information about a family's medical history, you're much better prepared for preventative care and screenings. As Dr. Graham said, early diagnosis leads to early treatment. And then you can also just be mindful of early signs of diseases. Many medical testing and screening for genetic issues, it's all based on your medical history. So without it, families are at a disadvantage. Next slide. So we have many medical and genetic issues reported on the DSR. Here's an example of two of them. We have cases of fatal heart conditions. In one case, large group of offspring with a fatal heart condition. The donor was not aware of it. There was a child that died, and many of the kids were also found to have this condition. In another fatal heart condition case, the donor did know. He, his mother, and sister had all had heart surgery, yet he didn't report this to the 3 clinics that he donated to. Subsequently, one of the boys, one of the donor offspring, had to have open heart surgery, and several of the other children also are affected with the disorder. What complicates this is that between 22 and 28% of donors, sperm donors, donate at multiple clinics, so this complicates it even more as far as tracing and keeping up to date with the medical issues. Next slide. So I think it's really important for prospective parents to know what parents of older donor kids are saying. We just published a study on 1,700 sperm donor recipients. And what they say is 93% of them would not use a sperm from a donor who had produced a lot of offspring with reported autism. 67% of the recipients thought that the sperm banks should have some kind of comprehensive medical and genetic testing, which they don't have right now. Right now, some banks test some donors for some diseases, and that's beyond the FDA requirements for STDs and a handful of other diseases. 78% wish that all donors were psychologically tested, and more than half of the parents who used anonymous donors wish that they had used open donors. Next slide. We've also done donor surveys for egg and sperm donors and published those papers. And what we know is that of our surveyed donors, 84% of the sperm donors had never been contacted by their clinics for medical updates, while 23% of them said that they or close family members did have medical or genetic issues that would be important for families to know about. 97% of egg donors were never contacted, while 31% of them said again that they had medical or genetic issues which would be of importance for families to know. 94% of our surveyed sperm donors said they would have accepted an offer for genetic testing had it been offered by the sperm banks. Next slide. So donor-conceived people can have a wide range of emotions as far as wanting to know their genetic relatives, half-siblings, and their donors. I know that my own son, until he was 15, when he finally did connect with his biological father, every candle he blew out on every birthday cake was with a wish, I want to know who my biological father is. So while, you know, he wasn't devastated or distressed in a great way about this, he definitely was curious for the whole way until he got his questions answered. Next slide. For some kids, it's a real struggle. Some kids feel very angry and very frustrated that somebody else has the information about their genetic, ancestral, and medical history, and they have no access to it. Just this week, we had 2 young men sign up for at the DSR, one saying this: I've lived 19 years with questions I was never willing to ask, 19 years of battling for an identity and feeling as there was something missing. And the other young man says, it wasn't until after I nearly died as a result of a medical condition that I realized not knowing half of my medical history was a serious problem. I'd like to know more if I can. I'd like to know if I have sisters and brothers. Next slide. So we also surveyed 751 donor offspring to see their feelings. I think as far as going forward in the industry, I think looking to the donor-conceived people is the first place we ought to be looking. So many of them are searching. The large majority of them want to know what the donor looks like. They want to connect with their half-siblings. But they also want to know more about their ancestry, themselves, and their medical history. And we can see that more than a third of them would like to establish a relationship with the donor. You know, these kids are not looking for a mom or a dad. They don't want money. They just want to know where they come from and the opportunity to get to know this person they're so closely genetically related to. Next slide. So we find that many of the egg and sperm donors that join the donor sibling registry are very frustrated that their clinics did not alert them that there was a place to make mutual consent contact, where they could share and update medical information and also inquire about the kids that they help to create. The sharing of information goes both ways. There are families who want medical information from the donor, but as many of these donors are going on to have families of their own, you know, it's of importance for them to know if any of the children they helped to create had any medical issues. So having a free-flowing back and forth exchange of medical information is very important. Next slide. So that's kind of where we come in. We can help sort of take away the middleman job from the clinics and say, send everyone to the donor sibling registry. That way we empower the families and the donors to make that connection on their own, anonymously if they want. Next slide. We have many people now who are writing us into their contracts at egg clinics and egg agencies where they establish contact right from the beginning. The donors can remain anonymous. It's mutual consent contact. They're both deciding. And we have some very, very happy families that have the opportunity to have this back and forth exchange of information. Next slide. So we also, in addition to facilitating the connection, we also provide support for the donor-conceived people, for the parents, for the donors. So we sort of help people figure out how to jump into the sharing of information, how to communicate with amongst themselves, how to sort of figure out what level is comfortable for them. Next slide. So sometimes it's very important for people to connect early, and parents don't realize this. I see people come to the donor sibling registry sometimes and say, well, I don't know if I want to connect now or if I should wait till my child turns 18 and let it be their choice. And what I say to that is there are a lot of donor-conceived people that I know whose parents waited, and the only thing that the children said was, why did you wait? If I could have known these people earlier in my life or grown up with these people as my half-brothers and sisters, why didn't you tell me back then? So so that's in the case of actually connecting with each other non-anonymously, but parents do have, parents and donors do have the option of remaining anonymous to each other as well. Next slide. So the first part of this, I think, is education. When parents understand the importance of the sharing of information and that their child might be curious and the importance of honoring that curiosity, I think that's when we can help people make better decisions, when they're making more educated decisions. Next slide. So again, we have more than 40,000 members, and we've helped to match 10,000, I think as of today, it's 10,265 people with either their half-siblings or their donors. So we've facilitated quite a bit of mutual consent contact, and we have some amazing success stories. Next slide. So this is how it would work. We have parents and donors. Well, first of all, anyone can come to the site and search the registry for free. You can come and see if you have matches, someone who posted under your clinic with your donor ID or number. Then people can come to the site. It's $75 for a one-year membership, $175 for a permanent membership, and that allows you to make yourself searchable by others. You can add a posting. You can contact other families. You choose the level of contact that's comfortable with you. If you want to remain anonymous and just share and update medical information, that's fine. If you want to share photos and still remain anonymous, that's fine. You can even share emails and remain anonymous. So what we usually see when parents and donors make the agreement at the beginning, as you know, before pregnancy, we see them come in and kind of dip their toes in and send very benign emails back and forth and kind of get to know each other. And sometimes they make agreements to be in touch once a year or whenever there's medical information. And sometimes we see people chatting back and forth as they're getting to know each other and learning to trust each other and trust that there are, you know, healthy boundaries there. Next slide. So what we think is that we're empowering the families. We're letting the families and the donors decide these relationships for themselves. We also, I should mention, the Finding Our Families is a new book. It's a first book ever for donor-conceived people and their families, and it covers everything from disclosure and telling and how to tell, why to tell, and then after telling, what if you have a curious child, what if you don't, what if they want to search, what if they find a half-brother or sister, what if they find 150 half-brothers and sisters. So how do we, sort of redefine family and move forward with these new relationships? And it can be a little bit tricky, but at this point there are many people that have come before, like myself and my son. We've had to figure it out. So at this point, we all have some advice to give about what works and what doesn't work. Next slide. So the way that it works when it's written into the contract right away with usually, so far it's been embryo donation and egg donation, the recipient covers the lifetime membership fee for both her and the donor. And usually there's an agreement to at least post updates once a year, certainly when there's some medical information. As of right now, we have 102 families on the DSR that are embryo families. And just this week, a 14-year-old boy that was created from an embryo matched with 7 of his half-siblings through the sperm donor side of that embryo. Next slide. So the role of fertility clinics, we know it's to help people get pregnant, and the fertility clinics do a great job with that. But that's not the end. It shouldn't be the end of the story. It should be assisting families also into the future, giving them the information they need, not just about getting pregnant and having a baby, but you only have a baby for a very short time. Then you're going to have a child and a young adult and an adult that might be curious about their genetic and ancestral backgrounds. Next slide. So I think that the clinics and the people, especially the therapists, mental health professionals at the clinics, have a real opportunity here to help educate the parents in many ways that people like me were never educated about how important it is to have that medical information and how important it is for a child to know the truth and there to be openness and honesty in a family. And then also, some clues about how to go forward with that so that it's not such a scary thing. Curiosity about one's origins is very normal. It's an innate human desire to want to know where we come from. It says nothing about your parenting, but I think parents need to be educated about that and prepared for that. Next slide. So again, I think the donors also have to be educated and counseled about what being a donor means. And, it's not donating blood. It's helping to create a human being who might someday want to know you and know about you. And I think if we pull the fear out of that and the stigma and, so much effort that this industry has kept on keeping the recipients and donors apart, and more look at the donor-conceived people and what their needs are, we're going to see that a very healthy sharing of information is the right way to go forward. And that is the end of mine. I think back to you, Dr. Graham.
Yeah. Just kind of talking about, what we can do in the future to improve access, and it's kind of some of the things that Wendy touched on. Expansion of programs such as the Donor Sibling Registry. Until I, did research for this presentation, I didn't know about the Donor Sibling Registry, and this is something that we are planning on joining. With our daughter, we created a book that has pictures, describes the entire process that we went through to get her, and this is something that we read to her from her birth, really. And she'll, a couple times a week, she'll say, "I want to read the book about me," and so we'll go read it, and describes everything. This is something she's going to grow up with, so she's going to know from the get-go how she was conceived, and we're not holding anything from her. But she's had access with a couple of her full siblings and will continue to do so. But we don't know on the egg donor side. We don't know if there's other half siblings out there. We don't know the medical history of the egg donor beyond what we initially had, and so this is something that we're planning on doing. And then increased access to personalized genetic testing. genetic testing has gotten so much less expensive over the last 5 years, even a year or two. It used to be that any genetic testing was $400, $500 up to thousands of dollars, and now there are private websites such as 23andMe that you can submit samples of saliva, and for $100 you can find out if you're a carrier for 50 different conditions. You can find out if you're increased risk for 150 other diseases, and there's no place else you can get that much genetic information about yourself for $100. I mean, it's an amazing deal, and something that we've done for our own kids, but and for ourselves, because this is stuff that we want to know in general. I mean, this is something that anybody can do, but I think as the information becomes less expensive, you're going to see more individuals doing that. Eventually it might come to the point where you could sequence the whole genome for $1,000. But there's limitations to that. I mean, like I alluded to with a lot of the polygenic disorders, things like personality and other conditions, you're not going to be able to just look at your gene profile and say, well, this is where I came from. I mean, there's a lot of conditions where you need to know the person, know the donor, and find out that way. And then, kind of like Wendy alluded to, just kind of having a database at the time of donation where, like the donor sibling registry does, where you can update whenever changes occur. And people want the access. They want to know the information, and people want to give the information too. They don't. I think more people are realizing that they've got the valuable information to give, and it's not so secretive. It's whether it's embryo adoption, traditional adoption. It's not the way it was 20 or 30 years ago, where everything was closed and no information. It was thought that no information was best. We know now that's not the case. That there's a lot of this information can lead to better outcomes if we know it.
Great. Well, thank you both so much. That was wonderful. I really appreciate you sharing your research and all of your work with us today. We have come to the question and answer session. As a reminder, you can submit your questions to Dr. Graham and Ms. Kramer using the Q&A feature at the bottom of the screen. We have had a couple of questions come in already, so we will just go ahead and jump right in. I believe this is for Wendy to start. Have you had much pushback from donors or hesitancy to join from donors? I believe they're referring to the DSR.
That's a good question. When we first started, we heard from many in the industry, you'll never get donors. They have been promised anonymity. And what we've heard over the years as donors have come to the site is promised anonymity. We were not given any choice. And I think when they're properly educated and counseled at the front door about what it means to be an open donor or a willing to be known donor, I think many of them are choosing that, and many of them, once they understand they don't have to be a dad to someone or a mom or pay for college, I think when they understand why the children want to have contact with them, it makes them much more willing to come forward and share information.
Just as a follow-up, have you seen any more willingness as the DSR has matured from donors willing to join?
Oh, absolutely, absolutely. We've got about 2,000 donors right now, and donors are signing up all the time, so at much higher rates than ever before. As each year goes on, we get more and more and more donors.
Okay, the next question. Are genetic disorders more common in children conceived using donor eggs, sperm, or embryos? Dr. Graham, would you be willing to take that one?
Yeah. There have been, particularly with IVF, there have been more genetic disorders linked to that, and I think overall it may double the risk of genetic disorders total. There's not anything really specific, but they're more likely to have problems. But in the genetic disorders, and this is talking about more like the multifactorial conditions, like things like autism and things like that. That it wasn't, even though it's a doubling of the risk, and research is going on all the time to determine if what the risk is and whether it does or not. But I think the latest research I've seen is that it can double the risk of things like autism. But then you're going from 1% to 2%, so it's not absolutely it's not a huge increase overall. It's just compared to baseline, it would be.
Okay, Wendy, we had a question for you. Do you know of anyone who has established any level of contact between donors and the children going beyond just emails, phone calls, through the DSR?
Absolutely. Absolutely. If you go to the Donor Sibling Registry website and up at the top click on Success Stories, just in the last maybe 4 weeks, there are 2 donors there who have posted their own success stories about getting to know the families and the children that their sperm helped to create. So those are 2 of the stories that you can read right away, but we have many, many really wonderful stories of people making friendships and relationships. My own son is an example. He has an amazing relationship with his formerly anonymous donor, and he got 2 new grandparents out of the deal. The donor's parents adore my son and took him on as a grandson. So you just never know how these relationships will move forward. It's a wide range.
And just to throw this out there, would you both be willing to speak about the benefit of speaking to donor-conceived children about their genetic history early on in life versus later on in life?
Well, I think a lot of the, like we alluded to in the presentation, a lot of these genetic diseases or multifactorial diseases start early, and the interventions are early. And like with the case of the colon cancer at an early age, or things like risk for obesity, risk for blood clots, risk for cardiovascular disease. Those are things that I'm counseling right now with no genetic knowledge. I'm counseling parents when the baby's born. This is what you need to do to reduce the risk of asthma, reduce the risk of obesity, reduce all these risks from the get-go. And these are kids that I don't know the genetic information on. If I do know the genetic information on, I'd be going beyond that for a lot of them, and recommending the whether it's early testing or to diagnose some of these things early screening. So yeah, I think as early as you can get the information, it's going to help you.
Well, and I can just speak personally. I know that my son and at least one of the half-sisters he has, their whole lives have had kind of birthmarks and little moles and black marks on their skin. And for years, when my son would go to the doctor, they would always ask, is there any skin cancer in your family? And there's none in my family, but, we said he's the product of a donor. We don't know the other side. It was not on the donor's profile at all, anything about skin cancer or melanoma. Now, when we got to know our donor, we found out that he had melanoma, his father had melanoma, and these are things that we never would have known because there's no updating by the sperm bank. And, our donor didn't know to update that information with the sperm bank. So donors are not being properly educated on the importance of calling in information. But even that, we know some cases where donors have called in urgent medical information. The sperm bank says they take the information. Then other families who have had children from that donor call in, and they're told, nope, there's no medical updates. So the information is just not shared. So it's very frustrating for us and the families because we don't have sometimes some really critical information. Now that my son knows his biological father and grandfather both had melanoma, now he goes in for screenings once a year, and they do the full body check. But we wouldn't have known that, if we hadn't have met the donor.
Great. Well, it appears that we don't have any other questions coming in, and we are at the end of our hour. I do want to take this opportunity to thank Ms. Kramer and Dr. Graham for being here today. We greatly appreciate it, and thank you for all the attendees for being here today, and we will look forward to seeing you at a future Embryo Adoption Awareness Center event. Have a good day.